a.m. PST. So I think we should probably start. We have almost 80 participants and moving up. So I think we should probably start with introductions. So first of all, again, I just wanted to thank all the panelists joining us today. Dr. Hwang, Dr. Ayoub, Dr. Arzala. It's really is a pleasure having each of your times. I know you're all very, very busy people. So thank you all for your time. Um, and for those of the attendees that haven't met me before, my name is Tasir. I'm based at Sidra Medicine. I'm a pediatric ENT. And I just wanted to quickly just say some introductory words before handing over to our moderator, Dr. Ayoub. This is only our second session for the Middle East Academy of Otolaryngology Grand Rounds online sessions that will now run year-round, every other month. Our first session was held 2 months ago. We'll be having sessions every 2 months, as I mentioned. We have our Rhinology session today and our Otology session in March. And really the vision behind these sessions is to provide free world-class education to attendees from all around the world with world-class speakers, and usually with a combination of a local regional speaker to kind of give it some context to the Middle East and this region as well. And so that's our vision. We have recorded lectures as well. I pasted our YouTube channel link on the chat function as well. So if you haven't subscribed to that, feel free and subscribe to that. This session will be recorded and pasted to that channel as well at the end of today. And then we will keep you posted as well once you sign up on all our future sessions as well. Okay. So I don't want to say too many words. I think this is going to be a very, very, very rich session. So I'm going to hand over to our moderator, Dr. Ayoub. And I have the pleasure of introducing Dr. Ayoub. Dr. Ayoub is a fellowship-trained rhinologist within Stanford Healthcare Division of Rhinology and Skull-Based Surgery. He did his medical degree at Stanford University. He then did his residency at Stanford as well, before moving to Mass Eye and Ear / Harvard Medical School for his fellowship in advanced rhinology and skull-based surgery. But Stanford had to steal him back. He really is an asset to whichever program he's at. So he was then recruited back to Stanford. And I think he's been there just over a year now. On a personal note, I was his fellow when he was a senior resident in his PEDS rotation while I was at Stanford. And I have to say he was one of the best and most hardworking senior residents we had during his pediatric rotation. I tried luring him to pediatric ENT, but I think rhinology was his first love. So thank you very much, Dr. Ayoub, for joining us. I'll hand over to you.
Thank you, Dr. Din, and great to see you again. Good morning, everyone, and welcome again to the second session of the Middle East Academy of Otolaryngology Grand Round Series. I have the pleasure of moderating today's event, and it's also my honor to introduce Dr. Peter Hwang, who is Professor and Vice Chair of the Department of Otolaryngology, Head and Neck Surgery at Stanford University, and he is Division Chief of Rhinology and Skull-Based Surgery. Dr. Hwang is a key opinion leader, renowned surgeon, and innovator who has unmatched positive impact on our field throughout the years. He's the former president of the American Rhinologic Society and co-editor of the recently published second edition of Rhinology Diseases of the Nose, Sinus, and Skull Base. Today's topic, turbinate surgery, addresses one of the most commonly performed yet nuanced procedures in our field. The inferior turbinates have critical physiologic roles, but they contribute significantly to troublesome nasal obstruction. The range of available surgical procedures each carry distinct advantages, but also potential complications. Dr. Hwang has published extensively on this topic and carries with him decades of unmatched experience. Please feel free throughout to put your questions in the chat, and we'll have time for a Q&A at the end. And before we introduce or welcome Dr. Peter Hwang, I'd like to pass it off to Dr. Arzala for a few words as well.
Thank you. Thank you, Dr. Ayoub. And, it's really a pleasure to see this happening and all the achievements the Middle East Academy are going through. is something that I love. I started with the Middle East Academy from 2015, and it's now almost 10 years. And every single event that we are having, from the physical events in Dubai to these virtual events, is actually something that I'm proud of. And I see all the teams in all subspecialties are expanding and really achieving and putting footprints in every single event that we are having. So it's something that I have a passion about, and that's why I'm here today. And the speech that I'm gonna hear from Peter today is that something that comes from his marvelous experience uh, in the very complex procedures, and also in the everyday procedures like the turbinate surgery. And when I was talking with Noel in about this, I thought a turbinate surgery, we cannot hear this topic, from anybody better than that Dr. Hwang is gonna speak about. And
Mhm.
just by the way, today I had one of my turbinate surgeries, something that we don't do a lot in a tertiary care center. Uh, very, I would say more we are more of, extensive sinus skull base approaches, but once in a while we have a turbulent case in the middle. So this is what we have done today. And I would love to hear what Dr. Wang is going to say about the turbinate surgery, to review the surgery that I have done today. I did an intraturbinal microdebrider. So let's see what Dr. Wang is going to speak about, and listen to his nice tricks in the turbinate surgery. Please.
Thank you, Islam. Thanks to everybody for this warm invitation to join you this evening. And I want to apologize in advance for my casual wear because I'm heading straight to the operating room. We're 7 a.m. Here in California. But it really is an honor to be with you. And as you heard, we'll be speaking about turbinate surgery, which I really do think is, while it's a very common procedure, there's a lot of nuance, and my practice has evolved significantly in my surgical techniques over the years. So even though this is a talk that I might have given before, it's definitely changed over time. So hopefully I'm able to share with you sort of the state of the art in this topic. Um, sorry, just some disclosures that I have. And we'll start with the inferior turbinate and move through the middle turbinate and then end with the superior turbinate. And anytime we do turbinate surgery, I think one of the key concepts to remember is that these are functional organs. And we may not even know all of the functions of the turbinates, but the things that we do know are very important considerations in how we manage them. So the warming and humidification effects, filtration, the movement of air through the nose, the sensation of airflow, these are all critical things when we do surgery on the turbinates. To reduce them, we need to preserve the function. So we know about the secretory function of the turbinates from histology. And endoscopically, if you look within the turbinate, this is an intraturbinal view with the turbinate bone removed. And you can see these are autonomic nerves. These are nerves that regulate the secretory function and the vasomotor components of the turbinate soft tissue. So we can incorporate treatments of these nerves in our turbinate surgery because we recognize the functional nature of the turbinate. Just to highlight the importance of warming effects of inspired air from the nasal vestibule to the nasopharynx, and humidification as well. A lot of this is attributed to the inferior turbinate based on the progression of air through the nasal cavity. So why would we do turbinate surgery? Of course, nasal obstruction is a primary indication. We will often recognize compensatory turbinate hypertrophy that relates to septal deviations. And this study that I highlighted here that was published in Rhinology showed that reducing a turbinate that's enlarged on the contralateral side from the septal deviation does bring clinical value for a patient. So we do treat turbinates that are hypertrophied in a compensatory fashion, even if they're not symptomatic, before septoplasty. You'll see some indications for maxillary sinus hygiene when we talk about megaantrostomies. And whereas maybe 10 years ago when I gave this talk, I wouldn't talk about rhinitis, or there would be a question mark about the role of turbinate surgery in rhinitis. I do think now, with our understanding of the contributions of the turbinate to nasal secretion and nasal congestion, we definitely have much more evidence that the symptoms of allergic and non-allergic rhinitis can be improved with turbinate surgery. So we can think about surgical approaches from the least to the most, and we'll talk about out fracture and some form of soft tissue resection. And total resection is really not something that we do routinely for nasal obstruction issues, and really should only be done for tumor cases. So starting with out fracture, this is a very simple procedure. It doesn't remove any tissue, so it may be a supplemental procedure. The technique that I would do if I were to out fracture would be first to infracture the turbinate by placing the device like a boy's elevator lateral to the turbinate, infracture to create a little bit of a fracture of the turbinate bone attaching to the lateral wall, and then out fracture. This does seem to be a durable change based on CT studies, but importantly, it doesn't address the vasoactive components of the soft tissue. So really, it's not going to be adequate as a standalone procedure. And nowadays, I don't really do much turbinate out fracture because I'm actually removing the turbinate bone as part of my turbinate reduction. There are a lot of different ways of managing the soft tissue. I'm sure that you have recognized or have experience with several of these modalities. We'll only talk briefly about thermal ablation because it's not really used that much anymore. And I think radio frequency, whether it's with Coblator or the Celon radio frequency device, I think is a very common technique, at least in North America. And the microdebrider technique is also common, as you heard from Professor Herzala. So diathermy was something that I think I did as a resident in the 90s with a spinal needle and putting it in the middle of the soft tissue and then just activating a monopolar cautery. It's really not a very controlled way of delivering energy to the tissue, and so there's definitely a higher risk of necrosis of the turbinate. So we don't really use this technique anymore when we have many other techniques that have much more controlled delivery of energy. The options for radiofrequency are both bipolar in nature, the Celon and the Coblator device. The Celon device, as you can see from company video, delivers energy along a probe that's placed within the stroma of the inferior turbinate. Now, the technique that's done here in this company video is not exactly the technique that I use. I actually will place this probe in multiple passes with short bursts throughout the turbinate rather than just a single pass as shown here. And I think I get nice results with that. I can definitely show a patient after 2 months there's a significant reduction of the turbinate soft tissue. For the turbinator Coblator device, it's similar to the other coblation devices that it has irrigation and suction. And it is, again, bipolar radiofrequency administered in a submucosal pocket. So these techniques are nice in that they're minimally invasive. They are adaptable to a clinic setting if you have the resources to have something like this in your office. There are mucosal sparing if you deliver the energy carefully. But the disadvantage of these techniques is they have a higher relapse rate than other techniques that actually resect the tissue. And there's, of course, an equipment cost associated with these techniques. So my technique of choice is the microdebrider reduction, a submucosal removal of soft tissue and bone. So the technique involves an anterior incision. If you use this Medtronic device, it has a built-in and dissect the subperiosteal plane, but we actually do an incision, which I'll show you in an upcoming video. And then I will do a subperiosteal dissection of the turbinate bone and remove that, and then remove the soft tissue with the turbinate blade. Before this blade was developed, I was actually using a pediatric microdebrider blade, which can be used in lieu of this specialized turbinate blade. We don't use any packing after this procedure. And then for the back end, the mulberry tip, it's pretty difficult to get the microdebrider to that area to do a submucous resection. So I actually use a monopolar cautery and I directly fulgurate this area. You can directly shave that as well with the microdebrider, which I used to do, but that does tend to cause more bleeding, and you have to be very careful for the sphenopalatine feeders that could cause significant bleeding. So it requires thorough cautery if you choose to do a direct microdebrider reduction. So here's a video summarizing this submucous resection technique. We make an incision at the head of the turbinate just inside the piriform aperture, and we're going to carry that down to the subperiosteal plane. So we're going to incise right down to bone, and then we're going to elevate this subperiosteal plane. After we do that, you can see we're elevating on both sides of the turbinate bone and removing that under endoscopic visualization. And then here, further posteriorly, you start to see the nerves. See, these are the nerves that I highlighted in that previous video. These are autonomic nerves. We actually even sampled these nerves and taken them to the lab, and they express the attributes of autonomic nerves. So these are the parasympathetic nerves that regulate rhinitis, which is why I think this approach is very effective for treatment of rhinitis associated with turbinate hypertrophy. Then the submucous resection with the microdebrider, and finishing with that direct fulguration of the posterior mulberry tip. So this aspect of the procedure is not mucosal sparing, obviously, but this is very posterior and does not lead to significant crusting, and I think is very effective. So you can use other devices that incorporate bipolar. This is the Olympus device that has a bipolar tip. So this has the advantage potentially of controlling bleeding during the procedure. And I don't use this device much. This was just on a trial basis, but I thought I would include that just to show you the other options that are available. So for a microdebrider technique, this is a sculpting technique. And I think this is a very nice technique because the soft tissue is removed in the moment and you're not relying on contraction of the tissue. You can perform this in the operating room or the clinic if you do have a setup for your office setting. This does bleed more, and so this is one of the considerations. We will use some hemostatic powders at the conclusion of the procedure when we do this in the operating room, and we just place that in under the flap to help with post-op bleeding. You might know about a different approach to the turbinate, which was developed and espoused by Richard Harvey and the Sydney group. And it is a submucous resection of the turbinate tissue, but it's the bone and the lateral mucosa. So what you end up getting is something like this, where the medial mucosa is preserved, the bone is removed, and the lateral mucosa is removed. So it tends to curl up. When I've seen the post-op photos of Professor Harvey's presentations, I'm always very surprised that there aren't more issues with this stump-like appearance of the turbinate. And recognizing that the mucosa is preserved on the medial side, I think this is why they don't see problems with over-resection. But in our technique, and I should have included a post-op photo, you really retain the form of the turbinate, and I feel like it's a little more difficult to preserve the lateral mucosa, but our turbinates tend to look like just a turbinate that's been decongested, and they look very healthy. So I think there's plenty of evidence to support this approach because Professor Harvey's published a lot about it, but at Stanford, it's not our preferred technique. Well, what about full resection of the full thickness of the turbinate? If you're going to do that, you want to just limit that to the anterior portion. I think this used to be more common in the 80s and 90s. I don't see people doing it very much anymore, but if it is something that you've seen or thought about, just recognize that there is evidence that a partial turbinectomy does have a greater physiologic impact compared to other modalities of turbinate reduction. So this is a study looking at mucociliary transport times, And when you had a partial turbinectomy, you can see there was an increased mucociliary transport time compared to radio frequency compared to baseline. Since there's lots of other techniques that preserve function, I don't think this is a technique that I generally recommend. And furthermore, histologic outcomes with partial turbinectomy are worse when you look at the healed mucosa compared to radiofrequency. So if we develop preferences clinically, that might be due to ergonomics or equipment availability, but certainly we want to recognize the literature too, and what does that say about these outcomes when we're making decisions about how to treat our patients. When you look at coblation versus microdebrider, what you see is that both techniques are effective, but there seems to be a divergence of outcomes beyond 1 year. So this was a study that was not industry sponsored. They took a group of patients in a coblation group and a group in the microdebrider group. And up to 1 year, they both showed good outcomes. But beyond 1 year, the coblation group started to have relapse, and the microdebrider group continued to be improved. And this is, I think, pretty broadly recognized. And so when I would counsel a patient, if they're looking for a radiofrequency technique, and maybe this is something that's advantageous because it can be done under local anesthesia in the office setting, I'm going to tell them that the trade-off is that they might need to have this procedure again. So in my hands, what I tell them is there's a 30% chance of needing another procedure within 3 years. Whereas if we do a microdebrider technique in the operating room, I'm going to tell them there's about a 10% chance of needing a procedure over 5 years. So I do think there's a significant difference, and that does sometimes weigh in for patients' decision-making regarding what technique they'd like to pursue. This is just published. This is a broad systematic review and meta-analysis that looked at these different modalities. And essentially, the microdebrider technique did show the best outcomes compared to all other modalities. It did have a higher side effect rate, such as bleeding, which I already acknowledged in my previous slide, and that was shown. But the overall rates of side effects and adverse effects was considered low to moderate. So for me, the trade-off is worth it. Patients are very happy with microdebrider techniques. It just takes a bit of time to master the technique because it's technically a lot more difficult. But I'm very happy with my outcomes. Now, you might consider a full thickness resection of the posterior aspect of the turbinate. So the inferior turbinate back here, if we remove this portion, this actually doesn't have any impact on considerations like empty nose syndrome, but this will help us to create megaantrostomies for maxillary sinus hygiene. So we might do this for cystic fibrosis or really just sinuses that have been chronically diseased where we just don't think the mucociliary function is there. So this is going to be resecting this posterior aspect of the inferior turbinate. We're preserving the anterior third, and then we're going to detach that inferior turbinate from its attachment to the medial wall of the maxillary sinus. And then we're going to resect the medial wall with a downbiting punch. You can see this is the medial wall. That's going to facilitate access to lesions within the maxillary sinus. This is also something that leads to improved hygiene for the sinus. So it's not only an intraoperative access advantage, but postoperatively irrigation is going to be much enhanced. And so, this is after that megaantrostomy. You can see that it's very well healed. The mucosa of the maxillary sinus is preserved, so it is a mucosal sparing procedure. So we don't see any problems with over-resection and empty nose syndrome, and it is a mucosal preserving technique. And we wrote up our experience in a couple of papers showing that the vast majority of patients do improve with this technique, and nobody got worse. So this is a technique that I can offer a patient with refractory disease. It's kind of a salvage procedure. We don't need to do things like Colbolux stripping anymore. We offer this technique, and we actually did a follow-up paper to our original paper in 2008, which showed that all of these patients had sustained improvements and durable improvements after 7 years of follow-up. And in that interval between the two papers, we had done an additional 94 patients also showing improved outcomes. So this is something that we do very commonly at Stanford and is a very tried and true technique for us for salvaging chronic maxillary sinus disease. Empty nose syndrome is something that we see a lot of here at Stanford. My partner, Dr. Nayak, is very well known and regarded for his work in empty nose syndrome. This is a very complex diagnosis that really exceeds the scope of this talk, except to say that we definitely see patients who've had overresection of inferior turbinates who then develop paradoxic sensations of suffocation and nasal obstruction. That's not every patient, of course. There are patients who've had cancers involving their turbinate that are removed, they have no problems at all. So there are probably psychological predispositions, but it's definitely a very difficult disease to treat. And fortunately, this is an area of interest for him. So I don't tend to see a lot of these patients, but you can see the technique that he does here with augmenting the inferior meatus to create more of a like a speed bump here for airflow. And that does improve the sensation of airflow for patients with empty nose syndrome. This can be diagnosed with something called the cotton test, which is in the office setting, placing a cotton ball in the inferior meatus here to replace this volume that's been lost by the turbinate excision. And if a patient experiences some improvement, then that's a sign that perhaps they could benefit from augmentation of this area. So in summary, for the inferior turbinate, I think all of these techniques that we've talked about are efficacious. They're just going to be differences in side effect profile, adverse effect profile, and outcomes that will influence your decision making. And in general, we just want to respect the function of the turbinates and preserve that whenever possible. So let's move on to the middle turbinate. When I was a resident, this was a very hot topic in the early days of endoscopic sinus surgery. The rooms were filled at our American Academy meetings with hundreds of people hearing the debates about, should you resect the turbinate or should you preserve it? And people were very passionate about it. I think that controversy has really died down now, and we recognize that the turbinate is to be preserved when possible, but resecting is also okay if there's an appropriate indication. But the original concerns that sparked a lot of the controversies were related to patients or to surgeons' poor understanding of the anatomy and the risk of things like CSF leak, olfactory loss associated with turbinate resection. With regard to the olfaction issue, actually, the densest distribution of neuroepithelium is not in the middle turbinate, it's in the superior turbinate, which we'll talk about later. So even full resections of the middle turbinate aren't really risking olfaction for most patients, but that's only one consideration when we're thinking about whether to resect the turbinate or not. This is a secondary consideration. This is a patient who's had a bilateral middle turbinate resection. On the patient's left side, you can see that turbinate healed in a vertical fashion, and there's a patent frontal ethmoid region. But on the right side, that turbinate remnant lateralized, it ossified, it obstructed the frontal sinus, and now the patient has had complications related to an obstructed frontal sinus that's iatrogenic, that's due to poor management of this remnant of the middle turbinate that was preserved. So do you really need to remove a middle turbinate to get more room in your fess? I mean, that's usually the main indication. And there's other ways to create room in the middle meatus for that so that you don't have to routinely resect the middle turbinate for access. One is septoplasty, and I do a lot of septoplasty. And I think for me, if I think that I might need it, it might be an issue for the surgery or for post-op access, I do it. And that actually has been shown that there are better FES outcomes associated with higher rates of septoplasty when examined in a blinded fashion. So I don't hesitate to do a septoplasty. You can do limited targeted posterior incisions like this one and just removing isolated portions of the deflected bone and cartilage. And see, so that actually offers a very minimally invasive approach to reduce a selected area of the septum that might be deviated. And you can see in this case, this patient previously had surgery where the turbinate was fully resected, yet there was still incomplete surgery here in the ethmoid, and that probably couldn't have been avoided if the prior surgeon had done a septoplasty to create better access. I do this procedure I call a middle turbinate shave, which uses the drill setting on the microdebrider at a 12K mode. And this is just to whittle down the lateral aspect of the middle turbinate when it's hyperostotic. So here's a thickened, bony middle turbinate, and we need better access to the middle meatus. So on the 12K setting, we can run the microdebrider on the lateral side. What this is going to do is trim away the bone and the soft tissue laterally to see how you can see how it creates that room. And then we'll cauterize the cut edge there. And that actually heals very well. So that's an easy way of creating greater access when you have a hypertrophied middle turbinate. And then there's medialization techniques. So the key here is understanding the location of the basal lamella, and we can create an incision in the basal lamella to relax the attachment of the middle turbinate to the orbit that will allow that middle turbinate to come to more medial position towards the septum. So in this case, it's an unoperated patient. The first step that we do in FES is not taking the uncinta down, but to actually make an incision right here through the basal lamella of the middle turbinate. This is the left side to relax the attachment so that the middle turbinate, the sagittal portion of the middle turbinate here, can move towards the septum, and this keeps the middle turbinate from lateralizing. To me, this is a more effective technique than just pushing on the middle turbinate with a freer, and we actually studied this and published that this relaxing technique is more effective in creating room in the middle meatus than simply just fracturing the middle turbinate. So this is the technique in action. So you can see the first step that we do is identify the basal lamella of the middle turbinate going behind the bulla, and then simply puncturing that with a freer elevator. You don't want to go too low. You want to preserve the inferior strut of that middle turbinate, but this then creates that medialization effect that gives you more room. And so after the procedure, once you've completed your ethmoidectomy, you should be left with a nice strut of basal lamella inferiorly here. As you can see that on both sides, that does not affect the structural integrity of the middle turbinate. And you can see the superior turbinate nicely seen here immediately behind the basal lamella. You can also medialize the turbinate by scarification. I don't think this technique is very popular anymore. But some people might still do it. You can create an adhesion here intentionally between the septum and the middle turbinate. I tend to find that if a turbinate wants to lateralize, that you might get an adhesion, but it'll still elongate and it won't really be strong enough to pull the middle turbinate to the septum. So I don't use this technique much. Sometimes you need to put a spacer in, and this is a Olympus very soft silicone stent that can be very effective. Or you can suture the middle turbinate to the septum. And so we use a Keith needle and a plain gut suture, and you can incorporate this into a septoplasty quilting stitch, or you can do this as a standalone suture. It takes a bit of practice to do, but you can see here, this middle turbinate really wants to be lateral. And when we've done a frontal sinusotomy, we want to keep that middle turbinate medial, so we just sewed that in against the septum. By the time that dissolvable stitch breaks down, the middle turbinate has adopted this medial position. So you can go through and through both turbinates like this, but if you haven't resected the septum, that might be difficult. Sometimes it's easier to do a figure of 8 to get that stitch in to secure the turbinates. The newest technology for turbinate medialization is this fixation device that is called the Turbaline, and it's a absorbable implant. You can see it's got a little spear end, and there's no knots that are placed. These little catches right here fix the device in the tissue, and it dissolves on its own. So I haven't had any experience with this device, but I'm aware of it. You can see how it is passed between the middle turbinate and the septum, and it holds those in place. So it's a pretty new product. I don't have any personal experience with it to report back to you, but you might see it being promoted. So what about turbinate resection? Of course, as I mentioned at the beginning of this section, there are going to be times that we want to go ahead and resect the turbinate. And these are some indications for me. Concha blosa is probably the most common indication for resection of the turbinate. It's a very straightforward procedure to do. You just want to make sure you resect the lateral half of the turbinate. You want to resect the lateral half, not the medial half, because the medial half is what attaches to the cribriform plate. And then in polyp cases, this is probably the time that I would actually consider doing a more full thickness resection of the middle turbinate, really the lower half. And this actually has been shown to improve long-term control of nasal polyps. So in these studies here with advanced stage polyposis, partial resection of the middle turbinate was associated with lower recurrence rates at 3 years. This is a patient that I just saw in my clinic with an excellent result in terms of polyp control. You can see that we preserved the upper half, but the lower half has been resected. You can see how this could potentiate delivery of topical steroid rinses to the posterior aspects of the sinuses that would be better than if the middle turbinate had been intact. So that's the theory and some additional studies supporting the use of a partial turbinectomy for control of nasal polyp disease. Of course, you have to be careful when you start to resect the middle turbinate. Don't over resect. Fortunately, this is not my video, but it was shared with me. And you can see so far it's an aggressive resection that hasn't led to a problem. But then the introduction of cautery is really the threshold that leads to breakdown of the skull base integrity. And here you can see a CSF leak. So that's a known complication, but this is an avoidable complication. So for the middle turbinate, we want to be mindful of function again. There are justifications for resection of the middle turbinate, but think through your spectrum of options and try to preserve the turbinate whenever possible. And lastly, the superior turbinate. This is really about using the superior turbinate as a guide to the sphenoid sinus. It's not something that I learned much about when I was in training, but we've recognized the importance of the superior turbinate, especially recently with the evolution of endoscopic skull base surgery that really works through the sphenoid to approach many skull base diseases. So we have to really understand the superior turbinate much better now. So one of the misconceptions of the superior turbinate, it's the highest turbinate that it sits above the middle turbinate. And that's not how we want to think about it. The superior turbinate actually is behind the middle turbinate, and it shares a common superior attachment. When you look at a CT scan at this level, it looks like they're stacked one on top of the other, but actually it's posterior and superior to the middle turbinate. So this is really more of the proper orientation of that superior turbinate relative to the middle. So let's look at some basic anatomy. So here you can see the middle turbinate, the superior turbinate, the sphenoethmoid recess. The middle turbinate basal lamella at this point is wrapping around to its coronal plane, and that allows an access through the superior meatus to the posterior ethmoid sinus, and there's the sphenoid. So when we're doing an approach to the sella or other transsphenoidal approaches to the skull base, we're going to collapse the basal lamella of the middle turbinate in an atraumatic fashion with a freer elevator. That's going to give us more room to then outfracture the superior turbinate. And of course, you have to be careful with this technique because it is attached to the skull base. But at this level, this is a safe move. And that gives you a view of the sphenoid that you can then open, followed by, as you know, septectomy and approach to the sella through a binarial approach. So that's the direct midline approach. But in FES, we're typically doing a transethmoid approach to the sphenoid. So looking at this view, removing the septum, and this is representing the middle turbinate and the superior turbinate. We're going to go through the ethmoid, so lateral to the middle turbinate and medial to the orbit, which is represented by this blue wall here. We're going to go through the ethmoid, and then we're going to cross over through the superior meatus and go medial to the superior turbinate to the sphenoid os. So this is what I mean, going through the ethmoid and then crossing over. This is the superior turbinate and the supreme turbinate here to the sphenoid os medial in that sphenoethmoid recess. So looking at a different view of this, this is the patient's left side. We're going to flip that diagram around so that we can look into an aerial view of the ethmoid sinuses. Anterior ethmoid here, basal lamella here, and then posterior ethmoid here. So when we look zoomed in and we cross from the anterior to the posterior ethmoid, we're taking down the basal lamella of the middle turbinate. And then we should see the superior turbinate here medially within that area after opening the superior meatus. Then, to access the sphenoid os, I usually go medial to the superior turbinate and find the os, and then resecting at the level of the os, minimizing the amount of superior turbinate that's resected and preserving as much of the superior turbinate as possible, we then enter the sphenoid. So looking at a cadaveric view, this cut edge of the basal lamella here represents this area here. The superior turbinate is visible on the medial side. Here it's not visible enough, so we need to resect more of the basal lamella to see that. After we've done that, you can now see we're in the superior meatus. Here's the superior turbinate, the posterior ethmoid here. We'll then cross over to the other side to see the os and then resect just at the level of the os a minimal amount of superior turbinate to access the sphenoid os and then widening that into the posterior ethmoid to create our sphenoidotomy. What about olfaction? I talked about the distribution of olfactory nerves, and it is more on the superior turbinate, which is why we want to be very conservative with the amount of superior turbinate that we resect when we do a sphenoidotomy. Fortunately, studies have shown that the olfactory marker protein is not extensively seen as an indicator of neuroepithelium when you do histologic studies in the inferior aspects of the superior turbinate. And so the higher you go, there's going to be more risk of injury to the olfactory apparatus. And so the superior turbinate is really important to understand, not only because it leads us to the sphenoid sinus for sinus surgery, but it is really the gateway to endoscopic skull-base surgery. So we really need to be comfortable with manipulating it, how to be safe around it, and how to preserve olfaction. Well, that's all I have. Thank you so much for your attention and sharing your evening with me. I'd be happy to take any questions at this time.
Well, thank you, Dr. Hwang, for an outstanding presentation and for sharing your expertise with the Middle East Academy of Otolaryngology community. We can all learn from your extensive insight on how to improve patient care. So thank you for spending part of your morning with us. We do have a number of questions in the chat. The first one, you said you do not use any packing with the microdebrider technique. Do you use some form of flow seal or nasopore or anything else? And then do you also operate, do you have these procedures as an outpatient day procedure?
Yes, so thank you for the question. So yeah, I use flow seal under the flap. 5 cc's is plenty, and I'll do that after finishing one side to allow hemostasis for that side. We then express out the excess flow seal, and it does seem to help with post-op oozing. I don't throw any sutures at the incision. Some of my partners do. I don't find that it's necessary because there is good apposition of the cut edge. And by using a needlepoint cautery, I don't find that there's bleeding there. I don't use any nasopore. I don't use any other packing like outside of the turbinate. And these patients all do go home the same day.
Thank you. And next question. Do you counsel patients about any concern for post-nasal drip when you perform a megaantrostomy?
I haven't actually seen that come up as a symptom that patients complain about. I do think there are some patients where you will see some retained clear mucus at the bottom of the sinus, the transition from the sinus to the floor of the nasal cavity. But patients haven't described that to me as bothersome. So I think it's very reasonable to discuss that. But I actually don't routinely talk about it. And I've recently thought about this. We're resecting a lot of the secretory tissue from the turbinate itself as part of the megaantrostomy, so we might actually be improving rhinitis. But it's a good thought to consider discussing post-nasal drip symptoms. Yeah.
True, given the nerves you were talking about.
Yeah.
And next question, what is your tip for middle turbinate shave in terms of the potential risk of getting adhesions or stenosis on the lateral side?
Yeah, it's a great question. We actually have data that a visiting scholar wrote up years ago because when I first started doing this technique, I thought for sure we're going to create significant crusting and adhesions. But the reality is when you do this technique, you're actually creating more room in the middle meatus. And so you don't actually get adhesions. And it's posterior enough in the nasal cavity, the crusting is fairly minimal. And we never wrote it up. I need to track down that data so I can share that with you. But we actually had a minimal adhesion rate because you've created room by reducing the middle turbinate.
Great. Next question. When performing the middle turbinate medialization with incising into the basal lamella, is there any risk, any concern, anything you would not do, or any specific location you
Are
would
there
do
any?
that?
Oh, no goes. Well, the main thing with that is not to extend your. Yeah, don't. So the question is like, what should you avoid with that technique? You just don't want to extend the incision too low. So you could transect the turbinate completely, or you could leave a very small strut that could recirculate mucus or destabilize the turbinate. So you just have to choose that incision point carefully.
Great. And the next question, is there any evidence that you know of for the specific location of nasal airflow sensor at the head of the inferior turbinate?
Boy, I'm not an expert in that. I don't know that there's anything specific to the head that's not distributed across the rest of the turbinate. I mean, I was always taught that, nasal airflow is most influenced by the shape of the anterior-most part of the turbinate. But as far as nerve sensors or distribution of um, heat sensors or like that evaporative cooling sensation. I don't know that the head of the turbinate is different from the rest of the turbinate. So sorry, I can't answer that question for you.
And then another question, somewhat similar, but is there any concern with performing a middle turbinate resection at the same time as an inferior turbinate resection when it comes to thinking about empty nose syndrome?
Yeah, that's a great question. I think Dr. Nayak, my partner, who is the empty nose expert, has described this technique, or sorry, described this finding of ENS where there's been middle turbinate resection causing ENS. I I just haven't seen it, and I'm pretty conservative with my turbinate resection. So I do think that if you're doing submucous resection of the inferior turbinate, that alone is not going to cause ENS. So that does free you to do more full thickness resections of the middle turbinate if you had to. I think it's a theoretical consideration, and there would certainly be like case level or case report level findings, I think, if you had that. I think I'm always having friendly debates with Dr. Nayak about that, but I think he would still also resect the middle turbinate. I don't think he would not do it, but it's something that he thinks about because he sees the most extreme cases.
Great. And when performing any cautery on the middle turbinate, do you have any specific advice?
I think in general, I routinely cauterize it, even if I don't see a bleeder. But the main uh, caution is when you have the little arterial pumpers, you really need to control those. And the rest of it is more troublesome oozing. I think if you over cauterize the cut edge, you can get some bone chips, necrosis of bone later on. That's kind of problematic to clean up and debride in the office. So I try to just find that balance of like really being happy with hemostasis, but not over cauterizing. But when you have an arterial pumper, obviously you have to be more aggressive.
Next question is more about pediatrics, but is there a minimum age where you would perform the inferior turbinate submucosal resection?
Uh, yeah, I would say, for me, I would do a submucous resection anytime that I would think about a turbinate reduction. I don't see that there's any differences in qualification of that technique versus a radiofrequency. At Stanford, most of my pediatric ENT colleagues are doing radiofrequency in the operating room. I think it saves time, so there's that consideration. But I think the submucous resection technique is more effective. So I think for any child that you would think that turbinate reduction should be needed, that you would consider a radiofrequency technique. As long as the child is going to be under anesthesia, I would do the microdebrider technique instead.
And one similar question lower down, but is there a specific age limit for you to perform any type of pediatric turbinate reduction or turbinate surgery?
I guess the youngest I've done it is probably 5 for extreme cases, but most of the time it's in conjunction with some other issue that requires the operating room. I've never gone to the OR just for turbinate enlargement. But I'm sure those cases may exist.
And have you found that doing an inferior turbinate reduction can impact the eustachian tube function?
Well, I think theoretically it can improve it. We actually looked at data on nasal airway surgery and showed an improvement in eustachian tube function in patients who had dysfunction based on the ETDQ survey. So I don't really know how to tell which patients are actually going to improve or not, but I do think it can be something that can improve. So, like for me, if I thought a patient might be a candidate for a balloon dilation of the eustachian tube, I would stage that. I would try to do the nasal airway surgery first.
Mhm. And then you touched on this in your video, but one of the questions, how do you control bleeding when performing an inferior turbinectomy? I usually get heavy bleeding even after the first vertical anterior incision.
Injecting the turbinate, topical epinephrine 1 to 1,000. If you don't have experience with that, you should discuss that option with somebody who has experience with that because there are some precautions that are necessary. That's a very good hemostatic agent. And then using the Bovie cautery device to make the incision. The other thing I think is you need to get down to that subperiosteal plane. If you don't make it down to the bone after the first incision, you will get a lot of bleeding because you'll be wading through the submucosal stroma, which is very vascular. So you really want to make a distinct incision all the way down to bone and then elevating that subperiosteal plane. It's like being in the right plane of a septoplasty. You'll get a lot of bleeding if you're in the wrong plane, but it'll be bloodless if you're in the right plane. So that's probably the key.
There are a few more questions if you still have time. I know you have to head to the OR. One is, how do you manage crusting and atrophic rhinitis after a patient may have had a severe turbinate resection?
Um, well, I think you have to wait it out until, like, so I would look for exposed bone because probably there's necrosis and the bone may be the source of the severe crusting. I don't think there's anything you can do once necrosis has occurred, except to wait it out. And then you have to figure out if there's any long-term disability associated with it. So that could take months. I mean, I saw a patient who had a radiofrequency procedure in another country and flew in, and they didn't even realize it, but after 6 months later, they were still crusting. It's because nobody really looked, and the surgeon that did the procedure didn't really follow up. So they were actually better after a debridement, even if you have to go to the operating room for it, debride all that dead tissue, and that's going to be the first step. Topical antibiotics may also help, antibiotic irrigations.
Great. Um, Last question. Do you perform turbinate reductions in patients also undergoing rhinoplasties?
Yes, I work with the facial plastic surgeons all the time. I don't do any rhinoplasty myself. So yeah, I would just come in and do my part, and it's a very good compliment.
Well, we've taken a lot of your morning so far. Thank you so much, Dr. Hwang, for your time, for answering all of these questions, and for your excellent talk. We really appreciate everything you discussed and all of your videos today. So thank you for joining us.
Thank
Thank you so much.
you. Yeah, I would say one last word. Thank you, Dr. Wang, for this outstanding presentation. I loved it. And it came just after, again, my turbinate surgery, which is by chance came,
Yes.
yeah, that's great. So what I did was an intraterminal microdebrider. And let me ask you one or two technical questions in that aspect. Do you do hydrodissection saline by saline before starting your intraterminal reduction with the microdebrider? Like, do you inject inside the turbinate first to
Just
make
with,
it easier?
I just use
Yeah,
lidocaine injection, but it's not really a hydrodissect. The goal isn't, I can't really hydrodissect the plane, so it's just for general hemostasis, but not really dissection. Yeah.
okay. So, and once you enter inside the turbinate, I saw that you are making a really wide space,
Mm-hmm.
exploring inside the turbinate with your endoscope and
Mm-hmm.
introducing the shaver under vision.
Yes.
What sometimes we do is we actually just dissect, like use the shaver as we are using a cuttle, inside the turbinate without really getting to see every single like neurofiber or bony piece that we are microdebriding. So
Yeah.
just use it as a cuttle, getting inside all the way to the posterior end,
Yes.
avoiding injury to the mucosa. So do you do all the time like this nice exploration inside the turbinate as you showed?
Um, I'm just used to looking directly. I would feel more comfortable, especially taking out the bone, that I would want to do that. So, but I think there's so many ways to do it. There's no correct way.
Oh, okay. And
Yeah.
does it happen that you perforate the mucosa at times while you are microdebriding posteriorly? So you just microdebriding, trying to remove the bone, but you actually perforate through the medial flap with the
Oh,
microdebrider.
well, that's kind of why we look, right? So we're
Okay,
removing the bone. We're
exactly.
not we're not microdebriding the bone. We're actually dissecting it and removing it. I don't think I can
Okay.
shave away the bone. So